Well, it is now my pleasure to welcome our third panelist to the stage for our panel On the Hill, What's Ahead for Health Policy in Congress. I'll now welcome Stephanie Quinn, another one of our fantastic Alliance for Health Policy board members, to the stage, who will serve as our moderator. Stephanie is a Senior Vice President of External Affairs and practice experience at the American Academy of Family Physicians, where she oversees the AAFP divisions of government relations, practice advancement, and strategic engagements. Prior to joining the AAFP, Stephanie was Vice President of Federal Government Affairs at Care First Blue Cross Blue Shield, where she led the company's federal legislative agenda on issues such as market stability, drug pricing policy, and social determinants of health. Before Care First, Stephanie was Assistant Director of Congressional Relations at the American Society for Radiation Oncology. And she also served as the Deputy Director of Federal Government Affairs for Horizon Blue Cross Blue Shield of New Jersey. Stephanie holds a combined degree in linguistics and Spanish from the Mary Washington College in Fredericksburg, Virginia. Directly to Stephanie's right, I welcome Wendell Primus. Wendell is currently a visiting fellow at the Brookings Institution, a senior economist and policy strategist with more than 4 decades of experience shaping federal health and budget policy. Wendell served for 18 years as senior policy advisor on health and budget to Speaker Nancy Pelosi, where he led House staff in developing the Affordable Care Act and contributed to major legislative achievements, including the 2015 SGR legislation, various budget agreements, and the drug pricing provisions in the Inflation Reduction Act. Earlier in his career, Wendell held senior roles at the Joint Economic Committee, the Center on Budget and Policy Priorities, and the Department of Health and Human Services. He also served as chief economist for the House Ways and Means Committee, where he worked on the 1983 Social Security amendments and numerous Medicare reforms. Wendell earned his Ph.D. in economics from the Iowa State University. And to his right, we have Charlotte Ivancic, another wonderful board member of the Alliance for Health Policy and a current partner at TDY. Charlotte joined TDY in 2015 as a partner after more than a decade on Capitol Hill, serving as a healthcare policy advisor to members of the United States Senate and the United States House of Representatives. She worked for Senator Bill Frist during his time as a majority leader, and more recently for Speaker Paul Ryan and Speaker John Boehner. Charlotte was instrumental in developing Speaker Ryan's Medicare proposals while he was chairman of the House Budget Committee. Later, Charlotte led the effort to secure passage of historic legislation to repeal Medicare's sustainable growth rate physician payment formula and replace it with a new payment system that rewards quality. Before working for Congress, Charlotte was a healthcare attorney in a D.C. regulatory practice. She also worked at Children's Hospital in Boston prior to attending law school at Boston University, where she concentrated in health law. Stephanie, the floor is yours.
Thanks, Kelly. Well, it's good to be with you all today. I thought we might dive right in and talk about what Congress is doing. Wendell and Charlotte, thank you for being with us today. So we are emerging from a historic shutdown. So I think from a context-setting perspective, it would be great to talk about what the dynamics were coming into that shutdown and what they are now as we kind of emerge bleary-eyed. You know, how are they going to approach their work and what are some of the lingering effects? Wendell, you want to start?
Okay, well, thanks to the Alliance for doing this, and it's good to be on the panel with my Boehner colleague and friend when we did the SGR fix. It's an experience I won't forget. But to answer your question, I think the Democrats had to do this because they had to show that there was some fight and that they cared about things. The issue was the ACA tax premium extension. And, you know, that was enacted as part of COVID. But if you ask Nancy Pelosi about that, it was not about COVID. It was about something that made the market exchange much more affordable. And as a result, 4 million people joined the marketplace. So it was not about COVID. I realize various people have said that. But they expired at the same time as the tax provisions expired. And the thought was when we did that in 2021 or 2022 that they ought to go together. Obviously, they didn't because the Republicans were in complete control. But that is what drove the debate. And, you know, for many people, the premiums are doubling. Right now, there is clearly an affordability problem in the marketplace. And I'll go out on a limb and say, when we get to the end of the next CR at the end of January, there could be a lot of other issues like power of the purse, mass deportation, shooting boats in the Caribbean that could also cause some tension, big tension between the parties.
And I'll just add, I think for Republicans, it really was about a COVID credit, right? Don't shoot the messenger, but I do think a lot of folks really thought, okay, this was an increase during COVID for a good reason. It was scheduled to go away. If the Democrats really wanted to see it continue, they should have prioritized 10 years of coverage of it during the Inflation Reduction Act. I just think that's mostly what many, even the ones that say ACA is here to stay, let's make sure it works. Like there are members that feel that way who still would have said we're not talking about whether or not we're extending the ACA. We're talking about extending an increase that came to be during COVID. So I think going into it, you didn't actually have a lot of Republicans that thought it was a crisis to let it expire. Clearly, right? If that had been different, I think the outcome would have been different. So there was a just general sense that it was okay to let it expire. And I think even now, kind of coming out of it, there's some acknowledgement that for a path forward, that probably needs to include something on affordability. But what we're seeing is them spend time on things that are not the extension of APTC credit. It's other ideas about affordability, right? And we could talk about that. And certainly this could be part of the 2026 agenda for congressional Republicans. But I think generally speaking, there wasn't a lot of buy-in that this was critical. I think that they have, again, other things that they think could be helpful, but this wasn't a cornerstone of something that they thought had to come to pass, and thus they sort of sat in it, right, for a period that went on a very long time. But I think, Stephanie, to your question and sort of point about the longest shutdown history, almost didn't matter coming out of it whether that had been 10 days or 40. I think what you have is a dynamic where ultimately Republicans feel like they didn't have to agree to it to get the government reopened, and they feel a little bit empowered that they don't have to do something about it going forward. So, we'll see. Obviously, there's going to be a vote in December on this, and I think Republicans are trying to figure out what they should offer up for members that don't want to vote for what the Democrats will put on the Senate floor. And I do think that thematically what we're seeing sort of swirl here will be part of what they continue to talk about in 2026. So
that's actually a good transition. So what do you think the back half of this session looks like? What do you think some of the must-dos are? And, some of the things we know that were not addressed, will not be addressed by the end of this year, and we have until January. What do you see as some of those things and what might work their way in?
Yeah.
Well, I think the main thing that's got to get done is obviously the appropriations process has got to be completed. That is definitely a must-do. And as I hinted at, I think that's going to prove to be difficult. The power of the purse, I know the ranking member of the House Appropriations Committee very well. And, Democrats are pretty upset with all the impoundments that are happening. The best example of maybe of that is the USAID. But there's a lot of universities that aren't getting their health funding right now through the NIH. A simple definition of the Constitution is Congress writes the law, the administration faithfully executes, and the judicial branch resolves statutory and judicial support. That is not what is happening today by any stretch, and that has Democrats. And I would also say this shouldn't be a fight between Democrats and Republicans. This should be a fight between the legislative branch of government and the executive branch of government. But that also is not what is happening. So in my mind, the main thing that's got to happen is, and I'll disagree with Charlotte a little bit. I take it that most Republicans agree that we didn't have to do the premium extension. But there are some Republicans in purple districts that really believe they need to do something And I have a little bit of skepticism. You know, in 2017, we waited for the replace part of repeal and replace forever. So I'm a little skeptical of whether we'll actually see an administration plan that really reduces healthcare costs significantly.
Mm-hmm. I would agree with that, right? I think it's hard to imagine. I mean, we've been through this before, right? There's the idea that something else comes to be that is the magic bullet. I think that there is a lot of acknowledgement amongst Republicans that what they are trying to now set out to do 3 weeks from now and possibly next year is maybe not a great idea, right? But still, I still think this is why this has been such a tough thing to square, is because you have lack of enough support for APTCs, and then you have not a solid separate idea that is meaningful on cost reduction. But I think in terms of the what else needs to get done, I mean, the items that Wendell laid out, that's pretty much it, right? Everything else in terms of the health extenders was taken care of until January 30th. There aren't really other things to do until then that are kind of must pass in the healthcare space. I do think looking at January 30th and thinking about the bills that sort of became a healthcare package at the end of 2024, there is a lot of interest in figuring out if those items, not exactly the same, right? Because there would need to be some changes given where we are. But if a package that includes sort of the thrust of the lower health cost package, if that's something that could move at the end of January. And I think time will tell, because that would need to be bipartisan work that they would include on whatever comes to pass on appropriations at the end of January. I think it matters a lot how December goes as far as the APTC vote and whatever Republican alternative there is, whether that can produce an environment that can produce a bipartisan healthcare package at the end of January. And I think if Republicans start talking about reconciliation kind of more aggressively, it will be hard to see how there would be a bipartisan healthcare package in January if the plan is then to move on quite quickly to reconciliation.
Yeah, that does seem kind of a lofty goal, and I think people are still licking their wounds from from how the shutdown dynamics played out. So if we look further out, we're talking post-2026. We'll have had a midterm. Maybe the composition looks a little bit different. The agenda could change. What do you see potentially happening, getting through this year?
In 2026, yeah.
Post 2026.
Oh, post 2026, yeah.
A little further out.
Yeah, I mean, post 2026 healthcare agenda, I think, feels pretty fluid based on how 2026 goes. Like, are we in an environment where we truly did nothing about APTCs? If so, how did that go, right? Was that a political problem for Republicans in the midterms? If so, I think you probably would have some leaning in on affordability. The one thing I will say that's, I think that the administration has been working on sort of affordability related to drug pricing. And I think that Republicans are going to figure out in 2026 for the midterms how to take some credit for that, right? If you think about, well, is there really nothing on affordability that Republicans have done? They could talk about that, right? And they may lean into doing that just to try to take some ownership of some changes on the healthcare front that came to pass under the administration. So I think that's something that could be sort of for next year that lends itself to what worked and didn't work when it came to the midterms. Was the lack of progress on APTCs, and I'm sort of assuming that lack of progress, something that created a different outcome for some of these members? Do they really feel like not having more of a healthcare agenda was a problem? Maybe that will kind of change what the last 2 years of the administration looks like. But I think the really big factor there will be, what does Trump want to do with the last 2 years? Is he still talking about drug pricing? Is he pushing for more reconciliation? Hard to know. I think that's hard for them to control for anyway. So I don't think they spend a lot of time wondering about that. It's sort of what's the here and now, But I think the outcomes of the midterms will be meaningful when it comes to 2027 and 28.
So the really big issue after 2026 is, and the previous panel talked about it, is aging. And both the HI Trust Fund and the Social Security Trust Fund are going to exhaust their funds in 2032. And if we have an economic slowdown, I'm not predicting it, but if we do, the trust funds will exhaust much sooner. And the thing you've got to realize about solvency issues, it's political pain. You cannot restore solvency to either HI or Social Security without increasing taxes or reducing benefits. And neither party really likes to talk about that because it is political pain. I do not really expect the Trump administration to tackle that, but whoever we elect in 2028 is going to have to tackle it in their first term. And I think whoever that person is going to decide maybe it makes sense to tackle it in the first year of their 4-year term. And whoever our next president is going to have to orchestrate the two parties so they go over this solvency cliff together. I do not see either party taking on all the political blame for doing what needs. And Lord knows our deficit at almost $2 trillion a year, interest cost at over $1 trillion a year, also needs adjusting or needs a solution. And obviously the solvency issues of the two trust funds will help in that endeavor. I mean, it's one of the things I came to Brookings to do. I put out a Social Security solvency package. And the thing I'm most proud of, I got 16 former members, 8 Republicans and 8 Democrats that basically wrote a letter to Congress saying it's a good place to start. But I think that is going to be one of the really big issues over the next pretty short time horizon.
I hope, right? Like, I deeply appreciate that. I mean, I spent almost a decade working for the budget committee with Paul Ryan on these very issues. And I so appreciate that Wendell is still spending time on it. I think the one thing that I continue to wonder, because, you know, I hear that, but I think, what is the action forcing event? Wendell and I talked about this a little bit right before the panel. And, you know, if you assume the next president has to address this, why? Why? Because inflation was out of control, because mortgage rates were too high, because we lost our ability to borrow. We couldn't meet our debt payments. What is the thing, right? Like, and I think that's just from the years of spending time on this with Paul, trying to convince people that this is the right thing to do and you must do this because X. It really doesn't work unless people feel that. And that is just the reality of it. So I think, sure, the next president should address this, but
well, my answer, though, to you, Charlotte, is pretty simple. And it just like what happened in 1983. I mean, the Social Security trust funds were exhausted just before they got it done. And if we do not do anything about the trust fund, I don't think any member, Republican or Democrat, is going to want to go home and say, because I didn't do anything, all of you Social Security beneficiaries, all 70 million of you, are going to take a 24% cut in benefits. I don't think any member wants to go home and say, oh, because I didn't do my job, you're going to take a big cut. And, you know, Social Security takes about 20 million elderly out of poverty. It takes another million children out of poverty. So that, to me, is going to be the action forcing mechanism. And I'm just saying, even if that doesn't occur until 2032 or 2031, I think our next president, and even this president, may change his mind. He changed his mind about the Epstein vote that was just held. So it could happen.
Yeah, I agree. Something like that would make a big difference. I just still wonder what happens when the Medicare trust fund runs out, right? Can we not? We will have members that think we could deficit spend our way out of that, right? So I don't know. We don't really know, but I think it would need to hit people in a meaningful way for somebody to feel like the political pain was worth it. So
So we've covered some of the major boulders in the road to getting things done in the near term. But if we could wave a magic wand, are there one or two pieces of legislation that you'd like to see Congress take on?
Well, I'll mention
Relating to health policy. Let's narrow the field.
Okay. Well, there's one thing that really has bothered me some time, and that is we just got the announcement of the Part B premium. It's essentially $203. You multiply that by 12 and then add in the Part D premium. It means that a low-income elderly at 150% of poverty, because the Medicare savings programs don't help at that income level, they're going to pay almost $3,000 in Medicare premiums for someone that is at 150% of poverty. That is a lot. It's like 15 to 20% of their income. Now, the same person in the marketplace, even without the extension of the marketplace premiums, at 150% of poverty, you pay zero premiums. And also, our wonderful Medicare program still doesn't have an out-of-pocket limit. So it forces a lot of the elderly to go out and buy a supplement plan. So if there is one thing that I would point to that really needs to be fixed, in my humble opinion, is this discrepancy between what we're demanding from low-income elderly versus what we're demanding from low-income non-elderly in terms of marketplace premiums. I can name some more, but I'll stop there.
Yeah, I think some of the problems I see coming are related to lack of payment pathways for certain things, right? And I think there is a big discrepancy in terms of what commercial plans figure out, because it makes sense for the patient and the coverage and all this, and what Medicare, frankly, is not doing, right? And I think some of that is just stuck with a certain subset of rules, and they can't nimbly figure out their way through it the way commercial plans can. But I see that, just taking sort of novel therapeutics as a one example of this, the entire field of medicine in terms of what people have available to them for curative therapies is going to change a lot over the next 10 years. And Medicare really hasn't figured out what to do about that. These treatments are expensive for a reason. They took decades to develop. They're truly curative or extremely helpful in improving the quality of life. They're not going to be in pill form, probably, right? So what is the delivery of that? And I think that's a piece that really deserves some time and probably legislation, because I think Medicare would say, well, we don't have the ability to just cover some of this, and we don't really have a clear payment path. Also, we need to do this in a lower cost setting, right? And so I think there are a lot of issues there, just looking at what's going to change for the program, for Medicare beneficiaries in particular, that I think Congress will have to wrestle with, that are major shifts. And those shifts are good ultimately in terms of what's going to be available to people, but it's something that we don't seem prepared for.
So I'll add one other thing. I mean, in this example I just gave you, obviously if your low-income elderly is on a Medicare Advantage program, a lot of the premium is sometimes not there. I mean, and I know a previous panel talked about all the advantages of MA. My answer to that is yes. We are, according to MedPAC, it's not my number, according to MedPAC, the almost 50% of the Medicare beneficiaries that are now in MA plans, we spend $804 billion a year, more than if those same individuals had been in fee-for-service. So they can do supplemental benefits. They can reduce premiums. And for $804 billion a year more, they ought to be providing a better health care, et cetera. But that discrepancy between traditional fee-for-service and MA is another thing that I think needs to change. That is too big a discrepancy. And I would argue that we should be lowering that MA reimbursement a bit, and then using some of that money to lower Medicare premiums for low-income elderly, giving Medicare a catastrophic out-of-pocket limit, and I can go on, but I mean, another thing we need to probably do is undo some of the damage of the big, beautiful bill in the Medicaid program, et cetera, et cetera. So there's other...
I have one other dream bill thing I'd like to put on the table, Stephanie. So, I think the other problem that continues to be an enormous problem that we just haven't quite figured out, and there are different measures that try to get at this, but it really would involve a seismic shift in a lot of different policies, is related to disparities. People face really disparate care based on where they live, who they are, how they were born, where, just their position in life. And I think that is something that that we haven't done an adequate job with that. And it's a problem that's gone on for a long time. When I worked for Bill Frist, I spent a year working on some legislation in this space with then Senators Obama, Kennedy, and Clinton. And that was an effort that was bipartisan. That was 20 some odd years ago, right? So what are we doing now? Because that problem doesn't seem to have gotten better, and it's gotten worse. And it's a rural problem. It's an urban problem. It's economic disparities. It's racial disparities. But I think that's something that really is kind of a civil rights issue of our time, right? People have dramatically different outcomes, results, access, and availability based on who they are. And that would be my sort of wish list, Bill.
And I'll mention one more thing.
We'll just go on. Yeah. That's right.
Well, again, relating to aging, right now, and we have Medicaid provides most or a lot of the long-term care service, or pays for long-term care services. There's some of us that believe it ought to be switched from the Medicaid program to the Medicare program. Right now, you have to be fairly low income to receive low income services and supports from the Medicaid program. My mother, who was in the nursing home, which makes her an outlier, for 13 years, received some of the benefit of that. But I think just, I'll ask you all a trivial question. I'll answer it myself, but guess which state has the greatest percentage of people over age 65? And a lot of you would probably guess Florida or Arizona, but it's not. It's the great state of Maine. My point of raising that is, states are not equal in terms of the long-term care population, if you will. Demanding that states pay a good portion of it, I think we ought to be thinking about federalizing some of that. I think we've got to provide more home care, which is not an entitlement through the Medicaid program. So there's a lot of things that we need to do in that space, again, given our aging. And I also think that I'm kind of a leading member of the aging population, born in 1946. So the baby boom generation and the fact that they vote could provide the political muster to actually do something about long-term care over the next 5, 10 or so years.
So we've talked a lot about some of the barriers, but there are also some risks and opportunities. And so I'd like to talk a little bit about what you see as some of the risks in the near and longer term for Congress as they take on some of these health policy challenges.
Well, yeah, I think it's a good question, because I think they seem to see a lot of risk in things that probably need to be addressed, right? just speaking to kind of some of the things that Wendell raised in terms of the need to do major reform in these areas like Social Security, that feels risky, I think, politically. So risks, I think there are a lot of political risks that it's just a matter of, are people willing to take that on? What feels good? What sounds good, right? I wouldn't have thought that that Republicans would take on the risk politically of cutting the Medicaid program so significantly, but there was a lot of comfort in doing that, I think, for a lot of the members. So I don't know. It's a good question, Stephanie. I think the opportunities are enormous, right? We just laid out a lot of possibilities that people, if they if they wanted to hold hands and jump together, there's a lot to be done. But I think the risk factor is one that just it's tough to see in like a midterms year how people think about doing anything really significant, right?
I'll just say, Charlotte said the key thing, and that is, are both parties willing to jump together? That is really what's key, and I think it's kind of risky for both parties because sometimes they like to distinguish themselves in order to attract political votes, et cetera, et cetera. But I think these problems that we've just mentioned, particularly the problem of solvency, is going to have to be something that both parties do jump together. And it's going to take, I think, a lot of political, what's the right word, charisma, political oomph. And I'll say George H.W. Bush, I think, did it right in 1990. I mean, he, quote unquote, broke his pledge of no taxes, but he said we need to do deficit reduction. And we got the three budget committees, budget, appropriations, ways and means and finance, leadership of both parties, leadership of both houses, et cetera. About 24 members sat around a table at Andrews Air Force Base for 2 weeks. There were some hiccups along the way, but they finally did get $500 billion done over a 5 or 10 year period. But the point is, both parties jumped together. And the one thing that Charlotte and I worked on together, the SGR fix, I mean, Pelosi at that time was minority leader, Boehner was the speaker, and Boehner said, I want to get it done. And the two parties did jump together. And the most miraculous thing of all is when the House got done, that other body called the Senate took it lock, stock, and barrel and didn't change one iota of it. And I actually got more compliments from Democratic members saying, oh, how wonderful it is the Senate didn't change a thing. But anyway.
Well, that actually is a good segue. And first of all, as someone who represents physicians, we are greatly appreciative of your work on SGR. So thinking if we can channel our inner Pollyanna that Liz Drinka was calling on earlier, are there areas of bipartisanship that you see looking ahead?
Yeah, I mean, people got together on that lower cost bill last year, and that there was a lot of interesting stuff related to transparency. I think there's bipartisan interest in site neutral, right? That's a big issue that people seem to agree on, and not all the solutions, but just cost of care is really different depending on where you are, and we should do something about that, right? So I think there are things that they could work on together. And actually, many of those things may feel a little safer in terms of, to Wendell's point, Republicans and Democrats may want to distinguish themselves from each other, certainly thinking about where Democrats would need to be going to the midterms. You don't want to work on too many sort of big things, right? But I think some of these issues that have kind of been out there are certainly places that could be worked on next year still together. That would be, I don't know, they could have some success doing that, I think, without a lot of problems that are related to it being a midterm year. I think the bigger problems that Wendell's identified related to just solvency and that, like, what do we do about those things? The holding hands and jumping piece is obviously critical. It's much harder than even what we did when we, were able to do that from our leadership positions, because we ultimately were giving something away, right? It was like, oh, we've got this problem, SGR really needs to be fixed, need to fix it together, but it wasn't going to create a lot of pain for people to do it, right? And I think that's the part that's hard about some of these bigger issues like Medicare reform, trust funds, Social Security is you're not doing something that's going to feel good for stakeholders mostly, probably, right? So your stakeholders are the constituents and you're creating a better future for them, but that's just much harder to wrestle with. So
I'll mention one other thing, and that's drug pricing. When the Democrats took back the House in the election of 2018, Democrats ran on For the People. And what that meant was we wanted to do drug price negotiation. And at that time, President Trump says, I'm the negotiator. I love negotiation. And so we tried to work with someone named Joe Onick with the Trump administration. But that didn't work out so well. And so in 2019, we passed the drug pricing twice and paid for Vision Eye, et cetera, et cetera. But now, well, I'll mention one other thing. The drug pricing was added in the Inflation Reduction Act. It is the only bill that I know of where every Democrat in the House and the Senate voted yes. Every Republican in the House and the Senate voted no. So it was kind of the height of partisanship. But on the other hand, right now, we are going to see, I think, in the next 6 days, 10 days, whatever, the new negotiated rates on the 15 drugs that they are negotiating on right now. And my expectation, and I'm not the only one in this town, we all kind of believe that Trump is going to demand more from pharma in lowering those 15 prices than the Biden people did. The Biden, those 10 drugs, the average price reduction was 22%. I think when you see the prices of these next 15 drugs, it's going to be considerably more. But we'll see. But my point is that there's a case where Trump has picked up the mantle, and I expect going forward, drug pricing may be a more bipartisan kind of thing.
Well, I just want to thank you both for being here. For everyone watching, I hope there are a bunch of young Wendells and Charlottes out there willing to work together to further health policy and go over the cliff together. So thank you.
If I could just for a minute, Stephanie, just point out that Wendell was recalling things from the 90s that he was working on. We're also lucky that he was a public servant for as long as he was. This guy is still writing papers about Social Security, right? I think Wendell and I once figured out he started working on the Hill around the year I was born in the mid-70s. So that dates me as well. But this guy has spent his life working on these issues, and we should all be appreciative of that.
Yeah. Thank you, guys. Thank you.